No, but really, as Matthew alluded to, it's really a unique time. He alluded to one, but I think actually there could be 3 therapies approved in 2025. He alluded to the MPS 3A gene therapy. Denali is going to file early next year for their DNL 310 product. And you heard Ultragenyx is going to file before the end of the year. Here. Okay. Okay. Thank you. Thank you, Terry. So what I want to do in this time we have is really just very briefly talk about the current treatment for MPSs, and then talk about new treatment strategies. I missed the first few minutes of Matthew's talk, but you're going to hear some of that redundant, but that's probably okay. We'll talk about crossing the blood-brain barrier by a modified enzyme. Gene therapy, we've already briefly heard about. Just comment about reduction substrate therapy, which is happening out there, but probably not well appreciated. And then anti-inflammatory. And some of the speakers following me are going to talk about 3 things, which I'm not going to talk about at all. In utero ERT, Ambrusco, and anakinra, so that you're going to hear that from other people. And so I'm not going to really talk about those 3 topics. Just want to say it, most of you are aware of this, but each MPS disorder is due to the deficiency of an enzyme. And that's really the key issue. That enzyme deficiency causes everything. The enzyme required for the breakdown or recycling of the glycans, these complex sugar molecules, which you all have to recycle, and we do. The primary enzyme defect causes the accumulation of GAGs. And that's really with the heart that we push to the FDA to say, this is the primary storage material. It's not a second other thing, but it's the GAG storage. What Matthew didn't allude to, and I won't really talk about, but there's lots of animal data. Patty Dixon has done a lot of that, showing that CSF neuronal content of GAG equals CSF GAG. Brain GAG equals CSF GAG. And if you lower one, you lower the other. And so that's an important observation that the basic research has formulated over the years and found to be true. Individuals with a severe form of an MPS disorder have essentially no residual activity. It's important to realize that. In terms of just treatment overview, enzymatic correction, the ability to correct the cells for MPS patients in fibroblasts, we can have done that for probably 50+ years now. My mentor, Liz Neufeld, realized that cultured cells were really small amounts of lysosomal enzymes. She referred to these initially as correction factors, but really those correction factors were the missing lysosomal enzymes. What she didn't recognize initially, but other people before her, and if she would have recognized the next statement, she would have won a Nobel Prize, I'm convinced, for this seminal work. But we have a very efficient mannose-6-phosphate receptor-mediated uptake of enzyme in fibroblasts. That means we have a means to get enzyme within the lysosome in fibroblasts. We put the enzyme outside. She was about 6 months behind other people doing that. And so that, she won the Lasser Award, which in the US is the precursor for the Nobel Prize. But if she would have discovered that first, and Kornfeld and other people recognized that before she did, but she was close, I think things would have been very different in terms of her winning the prize. But one of the more important concepts is you don't need a lot of enzyme. Correction of GAG metabolism in a cell, that is getting rid of that stored material, can occur with only 1 or 2% residual activity. You don't need much enzyme. The challenge is getting the enzyme to the cells. And this is from a review article I wrote years ago, just showing that, I'm not sure if we have it. Does the pointer show up at all? Does the pointer show up there or not? No. Proteins are made in a particular part of the cell called the rough endoplasmic reticulum. Over here, up in this area, they go to the Golgi, where lysosomal enzymes then get targeted with a mannose-6-phosphate onto that molecule, and that directs it. That pathway is not 100% perfect. Some of that leaks out, and that's what Neufeld discovered, a so-called correction factor. That can go back into that same lysosome, that same cell, but also a nearby cell. For example, this is a transplanted cell. This cell then can be corrected by a so-called bystander effect. We have 2 current approved treatments for MPS, hematopoietic stem cell transplantation, historically using bone marrow donor cells and now using cord blood, or intravenous enzyme replacement therapy. Interesting, the first MPS patient, Hurler patient who got a transplant was in 1981 in the UK. I estimate now there's been over 1,000 MPS patients who have an allogeneic bone marrow or more recently cord blood, and the bulk of those have been Hurler syndrome. Successful and stable engraftment in the severe MPS 1 patients has resulted in clinical benefit, somatic disease improvement. Unfortunately, we don't see the eyes or the bones corrected and increasing long-term survival. So there's clearly a need for more therapy for transplantation. I'll talk about that in a little bit. How does transplantation help the brain disease in MPS? We believe that the so-called microglia cells of the central nervous system are the source of enzyme, and they actually come from the bone marrow donor. Macrophages cross into the brain from the donor that it can make enzyme, and now these become microglia cells in the brain, and then they release small amounts of enzyme. And that's one of the challenges of MPS 1 transplant. You're not getting a huge amount of enzyme. You're getting some, but you're not getting a huge amount. Timing is critical because this process takes time. It takes 6 months to a year for these macrophages to really fully change the microglia content of the brain. And so right now, the recommendation is that patients with MPS 1 or Hurler syndrome should be transplanted prior to 2 or 2.5 years of age. At the time of transplant, be intellectually intact. Because again, as you'll hear me say in the future, this presentation, the goal is preservation. We can't correct damage that's already occurred. And it's my feeling that most clinically diagnosed patients have some degree of irreversible brain injury if they're going to have brain damage in the future. The outcome, the neurophysiological outcome, has varied widely after transplant. And Julie Isengard, who you'll hear about, talk about later, has really seen that. And other disorders have not done as well overall, even though there may be suggestions that if you transplant early, that may be the key, but that's not been proven yet for everybody. In terms of treatment options, clearly MPS 1 is really the treatment. I should say transplantation is a form of enzyme replacement therapy. But the disadvantage of that is that it comes with a risk. Transplantation is not benign. There's probably 10% or more mortality associated with transplantation. The better the match, the less the issues. As a lot of you appreciate, enzyme replacement therapy clearly is available for the number of the MPSs. We see routinely reduction of urine bag excretion and decreased liver and spleen size in the MPSs where they have that. Improved joint range of motion, pulmonary function, energy, and endurance occur in some patients after ERT, or not everybody. But typically what ERT does is prevent progressive disease, which is a hallmark of the MPSs. One of the unique features that we discovered with ERT is that patients feel better and have more activity. I remember more than once families coming up to me in the early trial days and said, particularly one family with MPS 1, "What did you do to my daughter?" She was 13 or 14 at the time. And mom said, "She used to be so quiet and never said anything to me. Now she wants to go out. She says no, and she wants to be independent." She just felt better. And that's one story, but there's other stories like that we have. IV ERT is clearly beneficial. The dose we probably use is not optimal for a variety of reasons, and it's not expected to help the CNS disease in any significant amounts. Probably a little enzyme gets across, but we haven't seen it really benefit CNS disease. And you can see we have currently IV enzyme for MPS 1, 2, 4A, 6, and 7. And a lot of the Sanfilippo families ask, why not us? And Matthew alluded to that a little bit because in Sanfilippo, there's very little physical disease. And these enzymes are not going to get into the brain as we currently do it with the standard recombinant enzyme. And so, but now we have a chance in the future really to start helping as ultragenic therapy is going to have a chance to help the 3A patients. enzyme is beneficial, and most of you in the audience who have parents or you're involved in enzyme, you realize that, but there's still more we can do. Requires typically weekly infusions. To say it's very expensive is probably understating the fact. It's incredibly expensive. And it does not treat the central nervous system or brain. Many of the physical or somatic tissues and clinical features have not typically responded to either IV ERT or transplantation. Synovium, the lining of the joints, the trachea, particularly in MPS 2 and MPS 4A, the bone disease across the board, cloudy cornea and MPS 1, for example, and carpal tunnel syndrome has really not responded. So these are some of the limitations we have in terms of PrEP. So there's lots of room for new therapies. So I want to talk about 4 different treatment strategies. You're going to hear about a few more after I present from individual speakers. But the first one I want to talk about is crossing the blood-brain barrier by a modified enzyme. What do I mean by this? Companies have taken the enzyme, MPS 1, actually MPS 2 or MPS 3A, and modified it such that it's attached to another molecule, typically an immunoglobulin or immunoglobulin fragment, that can then bind to a receptor on the blood-brain barrier. So what's the blood-brain barrier? It's unique to the brain. It basically helps the brain be not exposed to all sorts of noxious compounds in the circulation. So yes, it's a good thing because we have a lot of things that the body's exposed to that never get into the brain. Wherever else in the body, the capillaries, the blood vessels, are leaky and things go in and out. I want to focus on just one mechanism to cross the blood-brain barrier, and that this slide is so-called receptor-mediated transcytosis. In this slide, this is the blood up here, circulation, and this part is the central nervous system. And what you have is receptors, either proteins on the cell surface that help molecules enter the brain or have other function. In this case, for both insulin and transferrin, they help those molecules enter the brain, that is carrying iron and carrying insulin. And they can actually cross 2 membranes and then now get into the brain, and they can then correct the cells in the area. There's lots of capillaries throughout the brain, so almost all neurons are relatively close to any capillary. So all neurons potentially are exposed. And some people who do gene therapy would say that IV gene therapy should have potential to do better because every cell is much more closer, where if you put the vector into the spinal fluid, there's a lot more room to diffuse. Theoretical, but there's, that's just what people have commented on. So let's talk about actual treatments. The first one is JCR, a Japanese company who's developed a recombinant protein, JCR141. Consists of this picture you see of an antibody against the human transferrin receptor fused to the ironate 2 sulfatase enzyme. So this is the ironate 2 sulfatase down here, and this is the full antibody. And it's basically for every milligram of JCR, it's half a milligram of enzyme. So it's 1 to 1 roughly. So their treatment is going after the central nervous system disease. So the hope is this transfers or transports into the brain. So this product is approved in Japan at a weekly infusion dose of 2.5 milligrams, 2 milligrams per kilo for the treatment of Hunter syndrome since May of 2021. And you can see over here, the red are the severe patients, are blue, and you see CSF heparan sulfate comes down, but it's clearly not normalized. And then if you look over here in terms of a 1-year outcome, this is age equivalent in terms of cognitive function. You see that the attenuated patient, as they should, continue developing normally. The very mildly affected sort of similar. And then you have 2 patients here, the more severe patients, have tend to stabilize in that 1-year time frame. The FDA did not consider this data enough for approval in the US. And basically JCR is in the process of doing a 2-year global phase 3 clinical trial comparing their product at 2 milligrams IV weekly to Elaprase at a half a milligram IV weekly. And they started that trial in February of 2022. In this case, it was assessor blind, so patients knew what they were getting, but the assessors do not know what they're getting. So that was a compromise the FDA gave to JCR in terms of placebo-controlled. Still placebo-controlled, but it's easier families know what they're getting into. So the other company is Denali, which has a similar recombinant protein. They refer to it as DNL310. And that's this molecule here. So in this case, their molecule is a fragment of the immunoglobulin, or FC fragment, coupled to one molecule of ironate 2 sulfatase. And then the idea that binds to the transferrin receptor here, which is what this cartoon is depicting. So in contrast to JCR, which is doing a phase 2/3, we have actually now data from the phase 1/2 from Denali, and they have now treated 45 patients, weekly infusions, ranging from 3 milligrams per kilo up to 30 milligrams per kilo for a few patients. It's generally well tolerated. It's certainly more reactive than Elaprase. And even though all patients have been on Elaprase, it's still reactive. Both clinical and caregiver global impression scales have changed. This is an open label study. Suggests the majority of patients stabilize and improve across all domains at 45 weeks, 49 weeks compared to baseline. They have more future data that's consistent with that. To me, what two critical issues for this product that really are beneficial. You can see here CSF heparin sulfate has virtually normalized for most patients. But more importantly, some of those patients have pre-existing antibodies, and this product actually normalized those pre-existing antibodies, which is really important because a number of the severe MPS II patients make no enzyme whatsoever. They have nulls, and they all can have very high anti-drug antibodies. Denali is currently enrolling a phase 2/3 placebo-controlled trial. Again, a placebo-controlled trial of 2 years duration with DNL310 at 15 milligrams per kilo compared to the standard Elaprase dose. Matthew already has announced what I just showed here is that Denali and the FDA came to an agreement to allow them to file accelerated approval using the biomarker CSF heparin sulfate. I should say that Matthew was absolutely correct. There was a sea change. Prior to the Reagan-Udall meeting, companies were hearing, no, we can't do accelerated approval, And then after that, whatever happened internally at FDA, it's clearly been very beneficial because they really, the CBER division, the biologic division, has been much more in the past positive about using accelerated approval, but CDER, the drug division, has been very reluctant until very recently. So that's the new enzyme happening in terms of MPS. So what's the gene therapy horizon? I could spend actually the rest of the afternoon talking about all the past and the present gene therapy trials, but I'll hopefully limit that to about 10 minutes. So what is gene therapy for the families here? How many families typically have a good idea what gene therapy is? Or should this be a topic in the future where we spend a lot more time on? How many families are comfortable with gene therapy? How many are not comfortable knowing what it is? So I think I'll recommend that in the future, you have just a section of basic gene therapy. What is it? Would be a great topic for a future meeting. So I'll give you one of the ways I've sort of described it. It's a procedure which in DNA or genetic material for the deficient enzymes. So you take normal DNA, which we have in the laboratory for these different disorders. We introduce that DNA into a cell in the body or cells in the body. And then that allows the body to produce the enzyme where when you have MPS II, for example, or MPS I, you have a defect in the DNA that cannot allow the body to produce normal enzyme. Typically, modified viruses are being used to deliver the genetic material, but as Matthew alluded to, and I'll talk briefly again about the B cell therapies. So again, there's two types of gene therapy in general one can talk about. In vivo, where we actually do an IV infusion of the AAV, of the vector. And that's what Ultragenics is going to be proposing to the FDA to do. IV infusion of an AAV9 vector carrying the MPS IIIA constructor gene. There's other ways to do that besides AAV. You can do nanoparticles in other ways. The other is to take cells from the body to the laboratory, infect them with, or put the missing gene into those cells, and then give those cells back. And that's referred to as ex vivo gene therapy. You'll hear about both of those in a second. There's been lots of preclinical data in the last decade on MPS gene therapy. There's at least, probably more than that now, 20 human MPS gene therapy clinical trials that have been completed or in progress, and we're yet to have an approved therapy, but the hope is in 2025, we'll have that approved therapy for MPS IIIA and most likely, hopefully, for two MPS IIs. I'm not going to read all these, but this just goes by the different disorders in terms of MPS I and MPS II, showing the different trials that are either ongoing or will be going in the future. Matthew alluded to the ex vivo gene therapy for MPS II that Manchester is doing. I'm not sure they've dosed anybody yet, Matthew, but I think they've dosed one patient recently. Here's showing what for 3A in terms of the intrathecal study going on and the intravenous for Aviona, now Ultragenics. University of Manchester has a very successful ex vivo gene therapy for Sanfilippo in 5 patients at the university sponsored trial. 4 of those 5 have done remarkably well. Currently, there's no gene therapy for 3B, and there's a proposed intravenous AAV9 gene therapy through the NIH Bespoke program for 4A. So let's talk about some of these individuals. So there's been a phase 1/2 ex vivo gene therapy for MPS I by Orchard. There are 8 patients. This data is all published. These patients had a mean age of almost 2 years of age. They had still intact developmental quotients. Basically, as you heard from Matthew earlier, they took cells out of the patient, infected them with a lentivirus containing the missing gene, and did a relatively mild conditioning. And patients do very well with that. The risk of that procedure, autologous transplant, is much less than the standard transplants, and the follow-up is almost 4 years. One of the results is that this is some of the highest levels we ever seen in patients in terms of, I think, some of the MPS I dogs, I think Mark did have levels of this, but there were huge supraphysiological 5 to 8-fold normal levels of enzyme in the blood. I said earlier, 1 or 2% of enzyme can correct a cell. We saw stable cognition, improved growth, and normalization of joint mobility. We haven't seen that before in a clinical trial. It improves, spine findings and brain and spine. Radiological measurements were better. And MPS I ex vivo gene therapy provides superior metabolic correction in terms of Hurler syndrome compared to the standard transplant. It's really remarkable what these patients, I've seen pictures of them, and some of them have just, I can hardly recognize what they have after this. I'll say later, but there's now a phase 2/3 trial in progress for that. I'll come back to that. So in terms of MPS II AAV9 intrathecal, so in this case, instead of an IV infusion, they're putting the missing enzyme in the base of the brain area in the spinal fluid. They evaluated 3 doses. They needed immune suppression. And the pivotal data demonstrated that CSF heparan sulfate D2S6, which is a fragment, a disaccharide fragment, that's one of the more prevalent ones in MPS II, showed an 85% reduction. Here is there actually data of those fragments, of this D2S6 trisulfated disaccharide. And you can see they had, in the highest dose in yellow, dramatic decrease in that. 80% of the patients who received the pivotal dose, the highest dose, discontinued IV enzyme or remained treatment naive. And what happens is some of this vector leaks out of the brain and goes to the liver and makes some enzyme, but not enough for everybody. So there's still a need to monitor that. Subjects with cognitive function below -2. So we consider a normal range of function, 2 standard deviations, a certain range from the midline. And patients who had very low function really, demonstrated minimal skill acquisition, where if you had in sort of from 0 to -2 standard deviations, so you're decreased, but still somewhat in the normal range, they did much better. And this data shows that in terms of the patients who were very low when they started. And I should point out that sort of this white and the gray is sort of the normal range we consider plus or minus 2 standard deviations. And you can see these patients were already very low to start with, and at best they maintained. But if you had functions that were much higher at baseline, the outcome looks much better in terms of what happens to those patients. And not everybody is staying on the curve, but it's certainly much better than what we'd expect to see. So again, as I think you've heard from Matthew, the BNL filing, their new drug application is planned for this fall using an accelerated approval pathway with CNS heparan sulfate fragment D2S6 as their surrogate endpoint. So Ultragenyx and Abeona for 3A. So that vector was initially developed by Abeona, came out of Nationwide Children's Hospital in terms of who made the vector initially. Abeona went out of business a couple of years ago, and Ultragenyx acquired it. At the highest vector dose, we see reduction in CSF heparan sulfate with a mean reduction of 51%. The Bayley-3 cognitive raw scores showed a positive rate of change, indicating either stability or gains from baseline in 16 out of 17 patients during the expected window of plateau and decline. As you already heard, they previously announced to do this, and then more recently they got approval that they basically, the package is completed, and this, I believe, is the Fast Track program. Heather, correct? Fast Track or not? Heather, is it Fast Track? 6 months? You can't. I'm going to comment it should be a 6 month review period. So Matthew also alluded to another novel program. This B cells or plasma cells, or you can call them B lymphocytes, are white blood cells that circulate for long term. Some of our white cells are only very short term circulating, but these white cells are involved in antibody response, and they can secrete secreted proteins. So Immusoft has developed this ex vivo B cell gene therapy using this Sleeping Beauty transposon. That's just a way to put in to the B cells the gene of interest in terms of the DNA. Again, Matthew gave a little more detail. I'm aware of two adults who have been transplanted, Matthew. And their MPS 2 studies are in the planning phase for this in terms of. FDA has been very reluctant to go very fast. They really sort of drag things out because this is the first time that B cell gene therapy has ever been attempted in humans. And most of us appreciate the FDA is not sometimes very novel. They like to be very conservative. That is my comment. So the initial clinical data demonstrated reduction in GAGs and early evidence of clinical benefit clearly in the younger patients. Results from the MPS 1 ex vivo gene therapy are incredibly encouraging. And a phase 3 clinical trial is currently enrolling patients both US and Europe, and there'll be a 2-year study, and they'll look at that data after 2 years after everybody's enrolled. I would guess enrollment will probably be completed in the next month or two, from what I've heard. So I'm looking forward to seeing that data, but it's going to take a couple of years. And again, my comment, gene therapy is really emerging as a therapeutic strategy for treatment of MPS disorders. Lots of things happening with it. We need more details. And again, MPS 2 and MPS 3A gene therapy most likely will improve in 2025. That's my comment, Heather. So, too briefly, in the last few minutes I have, substrate reduction therapy. So what is substrate reduction therapy? Any idea of what that is? What is that? So enzyme replacement therapy is aimed to remove the stored material accumulating within the lysosome by delivering the missing enzyme. Okay, so that's what ERT does. Substrate reduction is to reduce the amount of synthesis of these accumulating compounds so that lysosome doesn't have a much burden to break down. So again, you can't get rid of these GAGs, but you can potentially decrease them. And this has been more successful in some of the other lysosomal storage diseases than we've seen in MPS. But I'll talk about what we know about MPS. So one nice thing about substrate reduction, there tend to be small compounds which can get into areas what ERT large proteins can't get. And again, for example, a goal of substrate reduction in MPS would be to decrease GAG synthesis and or glycolipids. So glycolipids are known to be secondary accumulation and toxic to the brain. So if you could decrease glycolipids, you may actually help the MPS patient. It's not a cure in the sense that it's not giving enzyme back, but it's sort of a supplement to help decrease the amount of enzyme you may need in that compromised lysosome. There's no approved medications. Historically, genistein, a soy isoflavin, was thought to be really, a lot of families. How many families here at one point used genistein? Anybody? I'm sure some of the people have used genistein. It's not really in flavor anymore because there's clearly a clinical trial in the UK that showed it really didn't do anything. But there was a drug in Europe, odaparacil, that looked like a great possibility. It's an oral antithrombotic agent with a good safety profile. But a phase 2-3 study showed some potential clinical benefit, but the company never really went on to pursue it anymore. So it's unfortunate we don't have that. And maybe that will get resurrected at some point again. But it looked like a nice supplemental medication. So I'm going to just, in the very last few minutes, talk about anti-inflammatory therapy. You're going to hear some more talks on that after this presentation. Camararo and coworkers a number of years ago now reported a marked improvement in MPS 6 rats when they gave a drug called pentasan polyphosphate, remarked an improvement in mobility, grooming behavior, and skeletal disease after oral administration. It's an approved drug in the US for something called interstitial cystitis, or inflammation of the bladder wall. There have been 2 small investigator-initiated trials in Japan and Germany that, had some partial benefits, but limited. But there's currently I want to talk about a trial in Australia with subcutaneous or sub-Q administration. So it's with an open label study for 72 weeks, a single center, giving weekly subcutaneous injections in 4 patients with MPS 1 who were attenuated. There were 2 doses. Initially, they gave them for 12 weeks weekly, and then it went to Q weekly for the next 72 weeks. In general, it was well tolerated. What they saw is decreased urine GAG fragments, cartilage degeneration with better biomarkers. There are decreased scores for pain tolerance and appeared to have some benefit, but needs a larger trial to show whether it can be helpful. And this would be an example of an adjunct to one of the current trials, because we know inflammation can have a significant role in some of the MPS disorders. I'm just going to show this. You're going to hear this talk from Linda Polgreen. Is Linda here, actually? Welcome. Good to see you yesterday. I'm glad you made it today. But I'm not going to talk anymore, but she's going to actually talk about, this is actually summarized from her publication of this study. So thank you very much. Question?
Thank you, Joe. We have time for one quick question. One moment, Michael.
Let's say in a few years, we still can't figure out at birth who's going to get
Michael, you got to stand up and.
Can you hear me?
Now I can hear you. Go ahead.
So let's say in a few years, we still can't figure out at birth among, let's say, MPS 2 positive, screen positive babies who will have neuropathic versus not, later. Do you see a day where we treat with both brain penetrant ERT and non-brain penetrant ERT sort of together as why not, right?
If one drug does both, then that clearly.
Or just the one, yeah.
I mean, right now, both JCR and Denali have products they're developing to treat both physical disease and the brain
Right.
disease for Hunter syndrome.
So that might be the way out. Yeah. Okay.